Before I go on to the next talk, I wanted to clarify something that some people asked about the pulmonary atresia intact septum. And the clarification is this, that what I meant was pretty much most centers will always cath a patient with pulmonary atresia intact septum. And that's not what I was talking about. What I was talking about, the success or the likelihood that the baby or the child is going to have a decompression of the right ventricle. That's what I was talking about. Cath is pretty much almost always done in most centers, but the decompression of the right ventricle is in question. And that's what I was talking about. And there are centers around the world that are pushing the envelope. What I try to give you is the current state of affair in majority or most of the centers. So there may be individual differences, which I didn't go into. That's just to clarify. Okay, so after the complex congenital heart disease, we want to make sure that we talk about left to right shunts, okay? And you would think you know everything about left to right shunt, and you may be right, but I may try to add few more bits of knowledge to all the knowledge you already have, okay? So again, I have no disclosure except I am an imager, so you will have a lot of images. So this is what I'm going to talk about. ASDs, VSDs, AVSDs. I'm not going to talk about unbalanced AV canal, PDA, AP window, AV malformation, coronary AV fistulas, just briefly. Okay, these are the things we'll go through: pathophysiology, epidemiology and genetics, clinical presentation, natural history, and timing and type of intervention. Okay, so the direction and magnitude of a shunt in a shunt lesion depends on few things, right? Size of the defect. Size of the defect is important. Small, medium, large, it is important. But if you have an ASD, the most important predictor of the shunt is the compliance of the ventricle, meaning by how stiff the right and left ventricles are, okay? Again, a board question to remember. Compliance or stiffness of the ventricle, not just the size, okay? VSD and PDA, the ventricular level shunt and the arterial level shunts, are dependent on the relative pulmonary and systemic pressures and resistance, PVR and SVR, pressure and resistance. And in AVSD, it's a combination of the above. The star comes back reminding you of the importance of, this in board questions. Okay, compliance of the ventricle. Now these things are dynamic, they change with age, okay? So there will be change in the compliance as the RV loses some of its thickness early in the childhood or infancy, and there is drop in the PVR, increasing the left to right shunt, okay? Neurohormonal changes that happens within in a patient with left to right shunt, there is a distension of cardiac chambers resulting in sympathetico-adrenal stimulation. Now, you have heard of systolic and diastolic function of the heart, but heart has an important endocrine function, and that is this. When there is stretching of the ventricle, there is stimulation of the sympathetico-adrenal system, and there is splanchnic, renal, and peripheral vasoconstriction or increase in SVR. Okay, this further increases the left to right shunt. So heart failure begets more heart failure because there is increase in renin-angiotensin, and then there is vasoconstriction, there is more left to right shunt, so it's a vicious cycle, okay? And then there is upregulation of myocardial beta adrenoreceptors, tachycardia, increased renin and aldosterone causes sodium retention, increased vasopressin causes water retention. Occasionally they like to ask this, and there is increased metabolism and O2 consumption. So on one hand, you have increased workload on the heart, not only because of the left to right shunt, but also because the systemic vascular resistance have gone up, and your kidneys are producing more renin, increasing the SVR. So, and there is water retention. So this is a vicious cycle. So chronic exposure to high pressure and flow results in medial hypertrophy of the pulmonary arteries, resulting in muscularization of the arterioles, and this is pulmonary hypertension, which is irreversible, or Eisenmenger syndrome, where the shunt turns from right to left. So if you're presented with a case where you have a baby who was going into heart failure, and now she's later in her childhood or his childhood, and she's relatively better, you may think that the patient is getting better. It may be true that the shunt is getting smaller, but also think about a scenario where the pulmonary hypertension is setting in and the left to right shunt is reducing. So a patient with shunt lesion getting better is not always a good thing, okay? Think about if the shunt is actually getting smaller or there is this Eisenmenger syndrome taking place, okay? Now, let's talk about atrial septal defect, the most common one. It constitutes about 8 to 10% of CHD. Incidence is about 10 in 100,000. Believe me, they won't ask you these numbers. They keep changing based on what imaging technique you use to look at them, okay? But you should know that the most common type of ASD in 75% of cases is the secundum ASD, middle in the center of the atrial septum, followed by the primum ASD, which is commonly associated with AV septal defect in 20%. And then there is sinus venosus ASD, about 5%. And then there is something called coronary sinus ASD, which is less than 1%. So the important associations that you should remember is the atrial septum is critical in right or left heart obstructive lesion because the entire cardiac output has to go through this atrial septum. So in hypoplastic left heart, DTGA, where there is important for mixing tricuspid atresia or TIA-PVR, the atrial septum is critical. So in any of these patients, if there is an atrial level restriction, you should intervene, right? Similarly, when you do an echo on a patient with these conditions, after PDA, the second most important thing to look at is the restriction of the atrial septum level, right? So think about that. Sinus venosus ASD is associated with PA-PVR. In my opinion, it is negligent not to make sure that the pulmonary veins are normally draining before sending a patient for intervention in sinus venosus ASD. Okay, we'll come back to that. Very common. Coronary sinus ASD is associated with persistent left SVC to left atrium. Why is this important? You can have a healthy looking child who is blue, right? Otherwise, completely normal. You look everywhere, do a normal scan, and they turn out to be okay because someone failed to look at atrial septum carefully. There's a left SVC draining into the left atrium because there is unroofed coronary sinus, and that causes a right to left shunt and cyanosis. Otherwise, the child is completely happy. I recently had a 10-year-old who was playing, going to school, doing completely fine. If you put the oxygen saturation probe on her, her saturation was 86%. Why? Because she had a left SVC to the coronary sinus that was missed, okay? So, non-compaction apical HCM can be associated with ASD. They can be sporadic or familial, okay? Remember this board question. Autosomal dominant kind of ASDs associated with conduction defect. So you have a scenario where a child has an ASD and father and grandfather had pacemaker and uncle died of sudden death, okay? Think about NKX 2.5, okay? These mutations can cause ASD and progressive conduction defect. They may not have conduction defect at birth, but you have family history. Think about that. There is homeobox gene mutation CSX that can also cause this kind of ASD and conduction defect. But NKX 2.5, board question. Other transcription factors, right, like TBX5 and GETA4 and 6 can cause it, where there is ASDs that are autosomal dominantly inherited, okay? Okay, another board question. If you have a patient who has abnormal hands or arms, okay, and they have an ASD, think about Holt-Oram syndrome. Their parents can have it. Autosomal dominant atrioventricular conduction delay is common, TBX5. NKX 2.5 and TBX5. Guys, please remember these, okay? Very important. Other syndromes, Noonan, Down, Klinefelter, Williams, Kabuki, Goldenhar, and Ellis-Van-Creveld can also be associated with atrial septal defect. And I will touch on one of these defects, which is quirky, but they like to ask, okay? So what are the physiological consequences? Small ASD typically does not cause any problems, right? And they close mostly spontaneously. What is a small ASD? Less than 3 to 4 millimeters is a small ASD. Moderate to large ASD can cause, RA and RV dilation because of volume overload, TR and pulmonary regurgitation, TR because of annular dilation eventually, Mitral valve prolapse, why? Because the ventricular septum is pushed towards the left, buckling the mitral valve, causing mitral valve prolapse. There's a definite association between delayed closure of ASD and mitral valve prolapse. Flow-related pulmonary hypertension. Now, pulmonary hypertension is extremely rare in patients even with large unrepaired ASD. But if you have a board question or a clinical patient comes to you, female, young female with an ASD, has significant pulmonary hypertension, and the only cardiac defect you find is an ASD, most likely, or you should test them for BMPR2 mutation, okay? Why? Because in presence of BMPR2 mutation, any shunt will accentuate the the formation of this pulmonary hypertension or development of pulmonary hypertension. So ASD in isolation typically don't cause pulmonary hypertension. Usually when it is associated with some mutation, they can cause Eisenmenger syndrome. Mostly asymptomatic, okay. Rarely exercise intolerance and fatigue. The very important finding in these patients are they are born with this ASD, like large ASD. And if you ask them, they say they're fine. Why? Because they have never experienced a life without this hole in their heart. They have always adjusted themselves to this condition, right? So oftentimes when you fix the ASD, they feel like, oh my God, this is different, right? But they never knew that they had a problem. So oftentimes they get better after the surgery, but before surgery they don't usually have exercise intolerance. Wide fixed splitting S2, okay, that's a common thing. Grade 2/3 or 2 to 3/6 ejection systolic murmur in the left upper sternal border, mainly because of increased pulmonary flow. Mid-diastolic rumble because of increased flow through the tricuspid valve in the lower left sternal border is a classic findings of an ASD. Again, even in boards or in your clinic, if you see a patient with murmur and if you see RS-R' pattern, the R' being taller, there is tall peaked P waves and right axis deviation, get an echo, guys, okay? Anytime you see RS-R' pattern, not the normal variety where the R' is bigger and the right axis deviation, you're dealing with probably a left to right shunt, okay? Classic EKG finding. Chest X-ray, cardiomegaly may or may not be present, right atrial enlargement, right side of the heart, RV enlargement, prominent MPA segment. Again, if it's a long-standing increased pulmonary flow, you can have increased pulmonary vascularity. Typically, if you look at the X-ray, it may be completely insignificant, right? Everyone knows an echo of a secundum ASD. If you don't know this, I'll be worried. But this is a small secundum ASD, left atrium, right atrium, subcostal, sagittal, and coronal views, very typical. They're more and more trying to incorporate imaging data in your exam because now it's computer-based. When I took the exam, it used to be a paper. You have to make circles on the paper. There was no way they can present these pictures. Okay, so mean gradient. Never measure peak gradient across an atrial septum. Why? Because the flow happens both in systole and diastole. So you have to always measure mean gradients, okay? That is important because the flow is almost throughout the cardiac cycle, okay? Right heart dilation, we all know there is RA, RV enlargement because of volume overload, diastolic flattening of the interventricular septum. If you hear that word, flattening of interventricular septum in diastole, you are talking about an RV volume overload. If there is systolic flattening of the interventricular septum, you're talking about a pressure overload. Remember these keywords. They try to tell you what they're asking. If you hear these keywords, think about those, okay? 3D is increasingly being used to define the shape and size of ASD, very useful for pre-device closure, assessment of the atrial septal defect. You can do TEEs, as you can see here. You can see multiple fenestration in an atrial septal defect, all of those things. Okay, sinus venosus ASD. Just like TAPVR, there are two kinds of cardiologists, ones who have missed sinus venosus ASD and ones who are going to miss it, okay? So if you see a patient with right heart enlargement, okay, and EKG changes, and the baby was crying, you never got a good look at the sinus venosus part of the atrial septum in this view, do not discharge that patient. There are so many cases of missed sinus venosus ASD. These patients will come back because they will develop complications, okay? So you have an SVC that is overriding this defect. There is left to right shunt, usually these are big. You can also get a bicable view, and you can see the sinus venosus ASD. Some people say it is not the deficiency of the atrial septum, but the deficiency of the inferior part of the right lower pulmonary vein. Those are good discussion and argument to be had between morphologists, but for you, it's a hole that is big and that causes right to left shunting, okay? And it can be missed. What else is important? What else is important is that, so there is SVC overriding this atrial septal defect, and there is a shunt. There are superior types, and there can be inferior types. In inferior type, essentially what is missing is it's closer to the coronary sinus, and I'll come back to that in a second. Okay, unroofed coronary sinus. Again, this is not uncommon and uncommonly missed. This is not a common type of ASD. In the 10 years of pediatric cardiology practice, I have seen about 4 or 5 of them. So once every 2 years we get this. So essentially what it is if you see as this patient is being scanned, you see at the end there is this deficiency in the lower part of the septum. It's an unroofed coronary sinus right there, right? That's where the ASD is. The ASD is essentially an unroofed coronary sinus, okay? That is causing a left to right shunt. Why is this important? Very commonly associated with left SVC draining directly to the left atrium. Why does the left SVC drain directly to the roof of the left atrium? Because it's not draining to the left atrium, it was draining to the coronary sinus, but since this is unroofed, it de facto drains into the left atrium. So embryologically, left SVC had all good intentions, but was screwed by this, coronary sinus. Does that make sense? Okay. Now, even in real life or in exam, if you get this case, there's a simple way to find out, very simple way. The 8-year-old I was talking to you about, though, the girl I was talking to you about, what we do is inject saline contrast in the left hand. Where does the left hand go? Left hand should go to the left SVC. And if there is opacification of the left atrium before the right atrium, you know there is a direct connection of left SVC to the left atrium, and you will be a hero in the echo lab, okay? So, LA fills before RA, unroofed coronary sinus. Cardiac catheterization, why is it important? Typically, most of the cardiac catheterization is performed these days for closure of the ASD, but if you are suspecting high pulmonary vascular resistance, you can perform cardiac catheterization to measure pressures and also to do reactivity study to know if you can close it or not. You can also look at pulmonary veins, but it would be a shame if we have to send a patient to cardiac cath lab for evaluating pulmonary veins, echo, MRI, CT, lot many things, okay. But if someone asks you a question, still, there are a lot of old school questions in your board where this patient was sent to the cath lab before the era of echo and MRI, there will be a jump in the oxygen saturation from SVC to RA, meaning by there is an LA to RA shunt. This can also happen in an LV to RA defect, right? Like a Gerbode defect. What is a significant ASD? A significant ASD is a QP/QS of more than 1.5 to 1, okay? We used to routinely send patients to cath lab to measure this, but cath is no longer the gold standard or the best test to measure QP/QS, okay? What is MRI? Okay, why? Because MRI has less assumptions compared to a cath's fixed principle, okay? So this is called a cine phase contrast imaging. Essentially, it's a flow imaging. You can measure flows in pulmonary artery and in the aorta, and you can get those flow diagrams. And you can see here, the pulmonary flow is higher than the aortic flow, and there's a QP to QS is 3.6. Very easy to perform. You can measure flows anywhere. You can measure relative flow differences in right to left pulmonary arteries. This is the way to measure QP/QS these days, okay? Not the cath. Okay, role of MRI and CT. I talked to you about this. If you have a patient with sinus venosus ASD, please send them to CT or MRI, okay? The reason is, even if you see 4 veins, the reason is sometimes the right upper pulmonary vein may be draining way higher into the SVC. And believe me, when the surgeons open the chest and they see that you miss the right upper pulmonary vein draining into the SVC and they have to close more than an ASD, they usually get really mad. You get a phone call, say, can you come up here? Why? Because they want to show you how you screwed up. So don't be that person, okay? Okay. Be ahead of the game. Scimitar syndrome, everyone likes to show this, right? The right pulmonary vein anomalously draining into the IVC. Again, ASDs, the sinus venosus ASD is most commonly associated with anomalous pulmonary venous return, 80 to 90%, okay? So they deserve an CT or an MRI. But 20% of patients, 10 to 20% of patients who require surgical closure of secundum ASD can have pulmonary venous abnormality. So it is your job as a cardiologist to make sure that all these patients who go for intervention, whether cath or surgical, they should have a good study to evaluate pulmonary veins, and they're normal, okay? So, we talked about role of MRI. You can always visualize the ASD and RV size in question. Eyeballing is no longer accepted method of evaluating RV. We have better methods like MRI is the gold standard. If you have any question about RV size, do an MRI. Okay. This is a critical thing that pediatric cardiologists are not taught a lot about. Why is ASD important? The ASD is important because if you don't close them, and adult cardiologists or adult ACST colleagues encounter this often, this missed because many patients are asymptomatic, they can have significant atrial dilation and atrial arrhythmias. As you can see in an unrepaired ASD, the prevalence of atrial arrhythmias increases with age. Why? Because atrium is stretched, it is scarred, it's a nidus, it is a, it creates an environment for reentrant tachycardia, just like the Fontan we talked about. Closure after 40 years, more prone to have new onset arrhythmias. Obviously, you want to close them earlier. This is an important fact I talked to you about. It may or may not be important for your board, but in real life, if you see a patient, young patient with ASD, secundum ASD and pulmonary hypertension, think about BMPR2 mutation, bone morphogenetic protein receptor 2. Once they develop pulmonary hypertension, they can have cyanosis, dyspnea, fatigue, arrhythmias, chest pain, hemoptysis, all kinds of bad things, PA thrombosis, stroke. Why? Because they have high hematocrit, okay? So all of those issues associated with Eisenmenger syndrome. Management of ASD, pretty simple. If you ask our cath colleagues, they will tell you that they have never seen an ASD they can't close, okay? But believe me, there are some ASDs they can close, okay? So then you send it to surgery. But the idea is to send an ASD that is hemodynamically significant, QPQS more than 1.5 to 1, right heart enlargement, abnormal chest X-ray, ECG. Otherwise, if they are small, wait on it, nothing bad is going to happen. Usually you can wait few years. Device closure surgery. In asymptomatic patient, preschool age is typically the time when, if there is right heart enlargement, you will close these ASDs. But in symptomatic patients, sometimes you may have to close the ASDs in the first year of life. These are patients who have significant pulmonary vascular disease, and the left to right shunt will accentuate the pulmonary vascular disease. So even though ASDs are typically closed in preschool time period, there are patients who undergo ASD closure in their first infancy or first year of life, especially if they have pulmonary disease because of prematurity or other things, right? Other reasons for closing ASD is paradoxical embolism, arrhythmias, pulmonary hypertension. Make sure if you have pulmonary hypertension, you check for reversibility or check for, make sure they respond. Now, one thing I want to emphasize here is, even in patients with significant pulmonary hypertension, if you have a significant left to right shunt, either at the atrial level, at the ventricular level, or at the arterial level at PDA, you want to close it at least partially. Why? The reason is, if there is left to right shunt, even in presence of pulmonary hypertension, if you don't close the shunt, the progression of pulmonary hypertension is going to be faster. Okay, that's one reason. The second reason is you cannot use pulmonary vasodilator effectively if there is still a lot of left to right shunt, right? So anytime you have a patient with QPQS of 1.5 to 1, even in presence of pulmonary hypertension, you should at least try to partially close the defect, right? Because it delays the progression and you can treat pulmonary hypertension more effectively. So that's an important point to think about. All kinds of devices. I don't want to show this slide, but I did because every day you will find our balloonatics or cath doctors coming up with new devices, right? To tell you about how they can close these ASDs. Complications are important. It's getting more and more important. There's an FDA warning. We can have fracture embolization, residual shunt, erosion of the aorta, device thrombosis, impingement of adjacent structures. Anytime you put a device in, you can entrap the valves, SVC, obstruction. Endocarditis can either be early or long, delayed. Okay, we have seen endocarditis 5 to 10 years after implantation of ASD because they are still not completely endothelialized. There are some rough areas. Okay, late erosion of the atrial wall or aorta, this is the most dreaded complication. This is why the FDA came out and said any patient who had an implant or device has to be followed every year to make sure there is no erosion indefinitely for now. Okay, so if you have patients in your practice, you should do that. Surgical management, we talked about. You patch the thing, anywhere you hold, you patch it. Only thing I will talk about is a Warden procedure, which you should know what it is. Warden procedure is a case where you implant the SVC directly to the left atrial appendage, right? Why? Because you baffle the pulmonary veins that were draining into SVC RA junction to the left atrium, okay? They could not create an intra-SVC baffle because SVC was not big enough, so the surgeon has to cut the SVC above the level of the pulmonary vein and attach it directly to the atrial appendage. The atrial appendage acts as a conduit or gives a length to the conduit. It's called a Warden procedure. It is performed in sinus venosus ASD with PA-PVR. That's the only thing you should know, otherwise it's baffle or, Post-op complications. One thing I would want you to remember in this, and that is the most common reason why post-op patients develop pericardiotomy syndrome is after ASD closure, right? ASD closure patients usually go home pretty quickly, except they have the highest incidence of pericardiotomy syndrome. Why? We do not know. There are conjectures. There are people who make up stuff all the time. They say it's because of the atrial shrinkage, whatever it may be, but it is common. So ibuprofen, steroids, colchicine, those are the treatments. But look for post-pericardiotomy syndrome. Usually you go in on third day to the patient's bedside and you're telling the patients everything turned out great. You're sending them home. You hear, and there's a rub, post-pericardiotomy syndrome. Okay, they will come back with effusion if you don't treat it. Okay, after the good old ASD, we move on to VSD, hole between the lower chamber of the heart. 20% of CSDs. The incidence varies depending upon when the scanning was done, because with echo, if you scan early enough, you can see small, tiny VSDs very often. So the incidence have varied. But it is the most common lesion in chromosomal anomalies, trisomy 13, 18, and 21. Everyone thinks that AVSDs are more common than VSDs in trisomy 21. It's not really true. Common VSDs, like VSDs can happen commonly in trisomy 21. But more than 95% of VSDs happen in the absence of any chromosomal anomaly, and the etiology is multifactorial. Okay. This is the most important thing I'm going to talk to you about today. I am still surprised by the amount of confusion there exists in terms of nomenclature of the VSDs and the understanding of where the VSD is, okay? So here you go, okay? Membranous or perimembranous VSD is the most common type of, after the muscular, small defects. It accounts for about 75% of VSDs. Now, membranous septum, if you look at anatomically, it's a tiny region. It can fit at the tip of your pen, like, the back of the pen. So for all practical purposes, all membranous VSD are perimembranous or paramembranous because it involves the septum around the membranous septum. So membranous and paramembranous are the same thing, or perimembranous are the same thing. And I think in terms of being a purist, paramembranous or perimembranous is more accurate, okay? Muscular VSDs, 5 to 20%. They can be in different parts of the septum. Inlet VSD, there is no confusion, thank God. And then comes the outlet, subarterial. They have all sorts of names. The names I come across every few years, I am blown away. They're uncommon. Okay, 5 to 7%. And this is another fact that people like to quote. They call it as Oriental VSDs. Okay, don't call it Oriental VSDs. Okay. The reason I will tell you, someone told me it's a Mexican VSD, and I'm like, well, that's amazing. The reason why it happens more common in Asian heritage and in Mexican or Latino heritage is this, okay? It's because the Asian people came across the Siberian land bridge to Americas, the North Americas, and they moved to South Americas. So they inherit the common lineage. So they carried with them this gene that causes the outlet VSD. So it's neither an Asian VSD or nor a Mexican VSD. It's just because they have the common heritage. But it constitutes a higher percentage of VSDs in the Asian population, about 30%. Okay, so that's National Geographic for you. Okay, so naming conundrum. Here I have listed all kinds of names people use, but all I want you to know is this. For effective communication between care teams, speak the same language. If in your institution they call it an outlet Mexican VSD, that's what you should call it, because then everybody is speaking the same language. That's all I want to say. But there is a ongoing effort to standardize the nomenclature. Now, this is another thing that many people have difficulty understanding. There are two kinds of VSDs, essentially. One, what is actual deficiency of septum, meaning by the ventricular septum is deficient. And the second thing is malalignment of ventricular septum, where there is actually ventricular septum, but it is not in the place where it's supposed to be. And these are different. And I will prove it to you that this is the way to think about the VSDs, okay? This is how, let's start with membranous VSD. It is located adjacent to the tricuspid valve. Extension is common because membranous septum is really small, okay? How is it closed? Aneurysmal tissue from tricuspid valve, prolapse of the aortic cusp. More commonly, the aneurysmal tissue of the tricuspid valve. As you can see, this aneurysmal tissue closing the defect here. This is the membranous VSD underneath the tricuspid valve in the short axis view. Short axis view is the best place to look at the position of the VSD, okay? There is, again, perimembranous VSD, large and small. There is the perimembranous VSD. This is a large perimembranous VSD. There is no extension into the outlet septum. That is just below the pulmonary valve. There is no VSD that is called inlet to outlet. Don't say it, okay? It makes you look illiterate, okay? So don't say it. It's either perimembranous VSD. If it is extending into the outlet septum, that's a different kind of VSD. This is the outlet septum, okay, right here, okay. 20% close spontaneously, most common by tricuspid valve tissue. As you can see here, the tricuspid valve does it best to create all sorts of tentacles to close this VSD, and then 20% may close with time, okay? Okay. The aortic valve prolapse can happen in perimembranous VSD, as is evident in this case. Here is a perimembranous VSD right here. The aortic valve is abnormal, causing some of the VSD to close. The traditional teaching is it's more common in the subarterial or outlet VSD, which is true, but it can happen in here less commonly in about 2 to 5% of cases. Increasing AR, okay, is an indication for surgery. Again, a board question. Even if the VSD is small, if the AR is progressively increasing, fix it. Okay, muscular VSD, I'm not going to go too much about this. They can be apical, mid-muscular, anterior, or posterior. Swiss cheese is when there are multiple. Okay, many of them close by hyperplasia and fibrous tissue formation. And you have all seen these pictures of large muscular VSD, small muscular VSD, and then there is Swiss cheese. I hope they didn't die of VSDs. But, you can see them. This is all I will say, that VSDs are like cockroaches, okay? You will ask why? Because the reason is if you find one, there are usually more. I cannot emphasize this, right? There has been so many incidences of people missing VSD because once they see one, they are all elated and they're happy they found one. But often there is other hiding. Sweep the entire septum. This is not a board question, but in life it will serve you well. Okay. Outlet VSD, okay? Deficiency in the conal septum. Okay, that is the definition of it. It is underneath both the aortic and the pulmonary valve, okay? Prolapse of the right aortic cusp is common. Aortic insufficiency is as high as in 30% of patients. All the names we talked about, subarterial, conoseptal hypoplasia, supracrystal, subpulmonary, doubly committed, okay? This is very important differentiation here. In a parasternal long axis view, typically a small perimembranous VSD is not seen. You have to tilt towards the tricuspid valve to see it. If you see a small VSD in a very good parasternal long axis view, you're probably dealing with a outlet VSD, as you can see in this. Now, this is not a great view to define the position of the VSD. That's where you have to turn to the parasternal short axis view. And here, you can see the VSD lying just underneath the pulmonary valve. So, if you have a clock face, I'll come back to that. So here, this is another view, subcostal sagittal view, where you can see that the VSD lies underneath the pulmonary valve and the aortic valve, right here. And that's a typical position. These two are the best position to look at the position of the VSD in terms of membranous versus outlet, okay? Aortic cusp prolapse is common, right one, increasing AR, fix it as you can see here in these patients. There is AR because of this cusp being distorted and pulled into that VSD, okay? Okay, another thing that you should remember. If you have a clock face, VSDs in short axis, parasternal short axis view, VSDs before the 12 o'clock position here, okay, is a membranous VSD. After the 12 o'clock position is a supracrystal VSD, okay? Why? Not because the heart knows the clock, because this is the supracrystal region of the heart. So if this area is involved, as you can see here, that is the deficiency of the supracrystal septum, and that's an outlet VSD. VSD here is in the membranous septum or perimembranous septum, and that is a perimembranous VSD. So this is a perimembranous VSD, this is a supracrystal VSD. Please don't screw this up, okay? Malalignment VSD, I talked to you about this. So till now we talked about VSDs that arise from deficiency of the septum. Now comes the VSDs that arise from malalignment of the septum. The reason why this happens is the conal septum developed from different embryologic cells than the membranous and the rest of the septum. So when the outlet septum attaches to the rest of the septum, it may attach normally, resulting in a normal septum, or it can be anteriorly deviated, meaning by the conal septum decided to move front. Okay, what is in the front? The pulmonary artery. As you can see here, the anterior malalignment of septum results in RVOT obstruction. If it decides to go back, there is aortic obstruction and you have an interrupted aortic arch. Okay, the conal septum developed from neuroectodermal cells, which is controlled by the 22q11 gene, right? So whenever you have a malalignment kind of VSD, always think about 22q11 deletion. And here, if there is anterior deviation, you can cause pulmonary stenosis. Posterior deviation, you can cause aortic obstruction and interrupted aortic arch, 22q11 deletion. So this is a completely different kind of VSD where there is no real deficiency of the ventricular septum, but in fact malalignment of the ventricular septum. Okay, we talked about this pulmonary hypertension. I won't go much about this, but I wouldn't talk much about this. But one thing I would say, this is a common question they like to ask. You have a child who had a small perimembranous VSD, you have been following them for many years. For 3 years, they didn't come back for follow-up because they went to Mexico, whatever, India, okay? And then they come back and you listen to them, the murmur has increased in intensity. Now it was 2/6, now it is 4/6 with a thrill, okay? What has happened to this child? Most likely what they're trying to allude to is a double chamber RV. So the high-intensity jet coming from the LV to the RV, hitting the RV free wall, leads to formation of muscle bundle in the RVOT, causing a high-pressure chamber before that and a low-pressure chamber after that. It's called a double-chamber RV. So that is another indication for surgery in a small perimembranous VSD. We talked about the first one, which is the progressive AR. Second one is a double-chamber RV, and the third one is development of endocarditis. Those are the three reasons, and sometimes, rarely, also there is development of subaortic membrane. So you close VSD because of hemodynamic reasons, or you close VSDs because there is complication that develops later. Okay, double-chamber RV. Please remember that. We know all this. If you holodiastolic murmurs are more common with big VSDs, this mid-diastolic rumble, I'm still interested in knowing how many of you actually hear this rumble, but I hear as you get older, you hear it better. I'm not sure. Ejection systolic murmur in the pulmonary area because of increased blood flow. Chest X-ray, pretty classic, big heart, increased pulmonary vascular markings. You should not miss this. Biventricular hypertrophy is common in patients with big VSD, especially in younger kids. They can have both right and left heart enlargement. Okay, the role of echocardiography is to define the type, size, and number, and increasingly 3D echo is being used to exactly define the size of the VSD because sometimes the VSD can be oval, star-shaped, or what it may be. Chamber dimension, estimate PA pressure, and associated lesions. Okay, so catheterization, more commonly done in missed VSDs to measure QPQS, measure PVR more importantly, and guide therapy with pulmonary vasodilation. So the reactivity study they do, that's the reason to do catheterization. Location and size of the defect, I would say we should be able to do that with echo. Okay, 3D echo we talked about. Okay, again, the same issue here. For measuring QPQS uniformly, I think cardiac MRI is way better than cath measurements because it's a direct measurement. You can get good estimate of QPQS. You can also see the anatomic VSD here underneath the aortic valve, perimembranous VSD that is partially closed by the tricuspid valve and aneurysmal tissue. Okay. Management of VSD, small VSDs, no treatment, moderate to large VSDs, diuretics and ACE inhibitor surgery and device closure. One word of caution for you, and again, gone are the days when you nurtured these kids with ACE inhibitors, Lasix, and an NG tube, okay, following up every week in the clinic. If you have a patient with significant left to right shunt, fix it, okay? The surgical risk has significantly gone down unless they have comorbidities. There is no role of chronic use of ACE inhibitor or afterload reduction in management of VSDs anymore. QPQS 1.5 or 2:1, aortic valve prolapse need to be addressed, severe irreversible pulmonary hypertension, either partial closure if there is still significant left to right shunt or leave it alone, okay? AV septal defects. Okay. Another important issue here, about 40% or 50% of kids born with Down syndrome will have heart defect, and of which about 40% are going to be AVSD, okay? So that's something to put things in perspective in terms of when you are talking or counseling families, okay? Now, AVSDs are a common lesion, especially unbalanced AVSDs are common in patients with heterotaxy syndrome. Right? Asplenia, polysplenia, AVSDs are common. This is another thing we talked about. Ellis von Crevald is a genetic syndrome where you can have a common atrium. This is occasionally being asked in the boards. If you see a common atrium, the thing you're thinking about is Ellis von Crevald. Okay. Anatomic features of an AVSD. There is AV valves are at the same level. There is anterior displacement or unwedging or a sprung aorta. Aorta no longer lies in between the annulus of the mitral and the tricuspid valve because it's a common valve. There is no place for the aorta to sit in there, so it is sprung or moved anteriorly. There is a cleft AV valve, which is a misnomer. It's not a cleft. It's that normal commissure between anterior and posterior bridging leaflet. There is counterclockwise rotation of the papillary muscles. These are the normal things that you see in an AV canal defect, okay? Now, this is another issue. People call these things all over the place, okay? Today I'm going to resolve your confusion forever, okay? One is complete AV canal, no question. There's a big VSD, big primum defect, complete AV canal, okay? There is no VSD, it's a partial AV canal. Only ASD, primum ASD, partial. No question there. Now comes the trap, transitional AVSD. What is it? Transitional AVSD is essentially an AVSD, complete AVSD, where the ventricular defect or ventricular shunt is small, okay? So the ventricular shunt is small. Now, the intermediate is really confusing. Why there is need for intermediate? The reason intermediate came into existence is because what happened was the AV valve, instead of being a common AV valve, there's a tongue of tissue connecting the anterior and posterior bridging leaflet, and that makes it intermediate, okay? Some people believe in it, some don't. If you read Moss and Adams, Dr. Frank Seta wrote this chapter, he's my mentor, I believe in it, okay? So, that's how it goes. But there is no confusion in terms of partial, complete, and transitional. Intermediate, you can take your pick. Partial, complete, transitional is a restrictive VSD, okay? Does that make sense? Okay, excellent. In a partial AVSD, they behave like a ASD, right? Partial canal, but they have higher incidence of left AV valve regurgitation because the left AV valve is abnormal. It's a common AV valve, and you can often hear the murmur of mitral regurgitation in these patients. When are they fixed? Okay, before that, there is this idea that all trisomy 21 patient should undergo echocardiogram based on the current recommendation by American Academy of Pediatrics. Why? Because the heart disease is very common. Now, I would argue that if you have a newborn trisomy 21 baby, you should do an ECG first thing, right? Why? If the ECG shows left axis deviation, okay, a superior axis, most likely you're doing with AVSD. Wait for doing the echocardiogram for about 2 days if the EKG is normal or otherwise normal. Why? Because when you do the echocardiogram on the first day, invariably you're going to find a PDA. And then you know what happens, okay? The NICU people will call you again in 2 days because they want another echo. And then the echoes goes on until the PDA disappears. So, it depends on how you look at it. If you're in a private practice, great. But okay, so this EKG, remember, superior leftward axis, okay, because there is posterior inferior displacement of the bundle of His because the membranous septum is disrupted, okay, board question. Catheterization, okay, gooseneck deformity, believe me guys, people always tell me that there is gooseneck deformity on an echocardiogram. No, gooseneck deformity was defined when people used to cath these patients and they used to get pictures like that, okay? Elongated LVOT is the right term. There is no goose on echocardiogram, only on the cath, okay, but they still like to ask. When do you fix a partial AVSD? Fix them in preschool years, 2 to 4 years. There is a lot of evidence saying that if you repair an AVSD, partial AVSD in the first year, their outcome is worse because their valves are not fully formed and repairing them is not good. In asymptomatic patient, wait till 2 to 4 years to repair them. Complete AVSD typically repaired between 4 to 5 months of age, okay? Pre-surgical consideration, this is very important. You want to make sure unbalanced, balanced, double orifice mitral valve or left AV valve is common. Parachute mitral valves are common. You want to not miss a tetralogy of fellow with an AV canal defect. Pulmonary hypertension is common. And in post-op, AV valve stenosis, AV valve regurgitation is common. Residual VSDs, LVOT obstruction, heart block, and progressive pulmonary hypertension. So what do you take away from this is a few things. One is the AV valve abnormalities and the AV valve apparatus abnormalities are so common that it is now routine in many centers to do a 3D echocardiogram to well define the AV valve and the papillary muscles, okay, before surgery. After surgery, If you take partial AV canal, a quarter of them, 20 to 25% of them, within the second decade of life will have reintervention. Why? The most common cause of reinterventions are two. One is left AV valve issues and LVOT obstruction. Okay? So in 80% patients, they don't need intervention, but in 20-25% patients, they will need intervention for LVOT obstruction and AV valve regurgitation, especially left more than the right. Okay? We talked about 3D evaluation being the standard of care in most tertiary care centers at this point to define the AV valve anatomy, because there can be a lot of variations. I would say AV valves in AV canal are like snowflakes. Okay? They can be different. Anyway, so you look at the papillary muscles. PDA. Okay, you know all about PDA. It's a connection between the aorta and the pulmonary artery, which is normally present, except in two conditions. One is in truncus, it may be absent, and second is in, I already told you, yes, absent pulmonary valve. I don't have chocolate, but I would have given it to you. But they always like to ask, the PDA being a embryonic remnant of the sixth aortic arch. Remember the sixth. Fourth is the normal aortic arch. Sixth is the PDA. Okay? Board question. Functional closure typically happens in 12 hours. Ligamentum or complete closure happens in 2 to 3 weeks. That's why sometimes when the patient comes back and is in shock in the first week of life, you can start prostaglandin and reopen the PDA because it's still not completely fibrosed. In preterm infant, it remains open in a significant proportion of patients. Why is it important? It is important because it can steal blood from the systemic circulation and shunt it to the pulmonary circulation. So you have a low cardiac output state causing oliguria, renal issues, intraventricular hemorrhage, neck, renal failure, and then lung disease. So all of these, right? So these have to be watched for. Clinical features are typical of a left to right shunt. The patient is breathing faster, diaphoretic, not gaining weight, big liver, so, hepatomegaly, wide bounding pulse, loud continuous murmur, mid-diastolic murmur at the apex because of the increased flow through the valve. Okay, PDAs, you should know. It's the pants view with an additional leg, extra leg here. It's bidirectional PDA. You can have a right PDA, as you can see here, rarely. You can have a left PDA. They can be small, big. But what is more important is if you see a curly Q PDA or a tortuous PDA or a reverse-oriented PDA, multiple names for tortuous PDAs, it means that there is significant RVOT obstruction. The more severe the RVOT obstruction, the more convoluted the PDAs. Okay, the more curly Q or more reverse-oriented the PDA. That's a fun fact to remember. Okay, Doppler is the way to know the shunting direction. This is a complete left to right shunt. Okay, never just do color Doppler. Also do spectral Doppler. Why? Our eyes are tuned to looking at red. We are not very good at blues, right? So often small right to left shunt is mixed if you are just visualizing it. But if you do Doppler, as they say, Doppler never lies. Echocardiographers lie, echo never lies, right? So there is always an image that shows you the real truth, even if you're lying. Okay, so the PDA, this is bidirectional PDA, small, big left to right shunt, and a small right to left shunt. Diastolic flow reversal in aorta is normal because there is in diastole blood flowing back into the pulmonary circuit. Okay, management in premature infant. Again, I occasionally come across these questions in the boards, and the first thing you should remember is there is no difference in the efficacy between ibuprofen and indomethacin in terms of closing PDA in a premature infant. So if the NICU people give you a hard time, tell them there's no difference. Okay. The only thing that I would say is indomethacin may have a higher adverse effect profile than ibuprofen. Okay, if you fail COX inhibitor therapy, surgery is the next option. Although there was a conference a few weeks ago in Midwest, I won't name the place, but the conference was on closure of PDA in premature infants. It was a 3-day conference talking about closure of PDA in premature infants, so it's increasingly becoming more common. Okay, so there are cowboys out there who will close PDAs in 800, 500 grammars, transhepatic access. NSAIDs complication, we talked about ligation. The complications are chylothorax, pneumothorax, vocal cord paralysis, because the recurrent laryngeal nerve crosses within the arch, and that's where the PDA lies, infection, all those good things. AP window. As the things, AP window, again, it's not a very easy pickup, because what happens is it's a connection between the aorta and the pulmonary artery, and in this short axis view, oftentimes you can see some dropouts. The best way to pick it up is probably a Doppler, and I will show you some images. This is a clear case of AP window. There's a connection between the aorta and the pulmonary artery. It can be proximal, it can be distal, or it can involve a large part of the aorta, giving a classification of 1, 2, and 3, which I think is ridiculous. Essentially, you're saying it's small, medium, or large, but that's fine. So here is an AP window. So you can see here as it plays, there is this connection, but there is more continuous flow, and here you can definitely see that connection here. Right there, it becomes 1, and then there is this Doppler flow. There will be more continuous flow into the pulmonary artery if you do Doppler imaging in the branch PAs, okay? But this is something you have to be careful about. 50% of them are associated with cardiac defect. Another board question which they like to ask is, what type of interrupted aortic arch is associated with AP window? And the answer is type A. It also has a syndrome name to it, Berry syndrome. The most common type of interrupted aortic arch is what? Type B, right. So type A is uncommon, okay? So, but it is associated with AP window. It can also be associated with aortic origin of the RPA, so isolated RPA, Al-Kappa, coronary artery abnormalities are not uncommon, tetralogy of Fallot, right aortic arch, and DTGA. Repair is surgical closure. One thing I want to emphasize here is AP window, like transposition, have a high incidence of progression into severe pulmonary hypertension. The shunt is very large, and these babies can develop pulmonary hypertension, Eisenmenger's pretty rapidly. Okay, so they need to be fixed soon. Miscellaneous shunt. I mean, again, I think this is important for board as well as in your real life. You will come across, if you practice long enough, a baby who presents to you, you do an echo. They did an echo because either David Driscoll, who was one of my mentor who is at Mayo, he's recently retired, but when I went to the clinic with him the first time, he had a baby, newborn or an infant, I can't remember exactly, but he was listening to the heart, then he listened to the belly, and lastly he listened to the head. And I was looking at him like, I thought he was joking. But then I realized, no, what he was listening for was a bruit. Why? Because you can have AV malformations, okay? What typically it looks like, it's like any other left to right shunt. There will be right heart enlargement, and if you do an echo, if you do a suprasternal notch view, you can see reversal of flow in the head and neck vessels. When you see that, think about AV malformation of the head, vein of Galen malformation, or AV malformation. If you listen to their head, it's very easy to pick up. You can easily hear a bruit. Okay, so high output cardiac failure. Sometimes they like to ask this. Heart is normal. What's wrong? Look at the head. If they have a big head, if they have a bruit in the head, they have a AV malformation of the head. Treatment, the most common is glue, fibrin glue, transcatheter embolization, or, so to reduce the size of the malformation. Pulmonary AVMs, the only thing I want to talk to you about pulmonary AVMs is this, that a significant proportion of pulmonary AVMs that are primary are associated with HHT, hereditary hemorrhagic telangiectasia. If you say this, it'll blow their mind, right? So, HST. But there are other acquired causes of pulmonary AVMs, which are more common. One is hepatopulmonary syndrome. Patients with significant hepatic failure, they don't get hepatic factor and they develop AV malformation. Same thing happened in Fontan. If the Fontan circuit is in a way that the conduit from the IVC is primarily directed towards one lung or the other, the lung that does not get hepatic factor will develop significant pulmonary AVMs, okay? If you have a heterotaxy patient where they did a Kawashima, okay, where there is no hepatic flow going into the lungs, between the gland and the fontan, they can develop significant pulmonary AVMs. So HST, hepatorenal syndrome, the hepatopulmonary syndrome, where there is hepatic failure and there is no hepatic factor, and then Kawashima and the fontans. How do you know patients have AV malformation? They're really blue, okay? I get these consult from liver people and they say, we're looking for significant AVMs. And I'm like, what is saturation? It's like 100%. I'm like, they don't have it. And they look at me like, what? I'm like, yeah, your saturation is 100%. How can they have pulmonary AVM significant? You exercise them, their saturation remains same. There is no significant AVMs. We all can have small pulmonary AVMs. That's not a problem. But if you have significant pulmonary AVMs, they're blue, okay? So that's what they look like. Catheter embolization is the way to do it. Coronary AV malformation, you see small coronary AV fistulas often, okay? They're in the pulmonary artery, you see these flames, and people get very excited about it, okay? If you see your techs, they have scanned, taken 20 pictures of it, because they want to make sure you have seen it, right? They are usually not of a big issue, right? Big ones, there can be big malformations that can drain into all chambers of the heart, typically atria, but also into coronary sinus, and they can cause coronary still phenomena, myocardial infarction, huge ones we have seen. How are they addressed? They can be addressed either by transcatheter embolization if they're symptomatic, or by surgery, okay? So, to summarize, key points: left to right shunt result in pulmonary overcirculation. Knowing the natural history is important for management. Short and long-term post-op complications are critical to understand. And shunt reversal is a bad thing, okay? So thank you for your attention.